So it's my pleasure to introduce Kathy Glass to everybody. Kathy and I have been pretty close friends for probably 10, 12 years now. She's Associate Professor at Emory. She runs their CT Fellowship program and is co-director of the Cardiothoracic and Anesthesia Division. And today she's going to talk about intraoperative TE evaluation of mitral valve. Kathy?
Thank you, Scott. Thank you all for inviting me down here to visit and speak to you today. I understand this is the full anesthesia department, so not a lot of you do intraoperative mitral valve evaluation. This lecture is designed to talk mostly about evaluation within the cardiac OR, since obviously we spend a lot of time utilizing this information there. But as basic certification becomes available and TEE moves more into the realm of monitoring for other procedures, I think you'll find it to be helpful there as well. So first thing I would like to do is disclose the fact that we went fishing yesterday, and I actually caught a fish for the first time ever in my adult life, and so we had a lot of fun, but I have no disclosures financially related to any companies, monies, etc. That one was 10 pounds, I think? Okay. So I'd like to start with a little bit of literature just to help you understand why echo evaluation of the mitral valve is an issue, and things that we think of and the surgeons think of related to mitral valve operations. So Stewart et al. At the Cleveland Clinic about almost 20 years ago now looked at the incidence of change in the surgical procedure for mitral valve operations once the patients made it to the OR, and found a pretty significant incidence of some sort of change, either change in what they were repairing, whether or not they needed a replacement, whether they needed to go back on bypass to fix something, etc. They followed that up 5 years later and found that 5% of patients may need further surgical intervention based on echo results post-bypass. Their conclusion was that they were doing harder repairs, but there were unchanged post-CPB problem rates. So what a lot of people take from this, even though the data is old, is that TEE is very important for intraoperative evaluation of the mitral valve, especially for mitral valve repairs and also for mitral valve replacements. And there's a couple reasons for that. One is that the echo can give you very specific information related to leaks, regurgitation, stenosis, etc., that you can't necessarily determine with your standard hemodynamic monitors, and you can't actually see it surgically. They can't feel a thrill like they could across an aortic valve that had regurgitation or stenosis, etc. And because of this and many other things, mitral valve repair is actually a Class 1 indication for intraoperative TEE, and we talk a lot about what to do in the patient population where you're concerned about doing the TEE and they need a repair. It's clear they need some kind of echocardiographic evaluation. So then a study at the Mayo Group, over 3,000 patients, came up with very similar data related to changing what was going on. So there's a few pieces of information that we can glean from this. One is that as anesthesiologists, we're focusing very specifically on the mitral valve evaluation, specific anatomy of the leaflets, and the cardiologists are now catching up to this, and they are now spending a lot more time when they're doing their preoperative echoes looking at specific etiology of disease. And I think as the years go by, as they get more in tune with what the surgeons want and need for information, we'll probably see less intraoperative change related to preoperative status, but then there's also off-pump as well. So one of the questions we struggle with is how much MR after your repair is too much MR, and that has actually been looked at. You come off bypass and there's a 1+ leak somewhere, or there's a paravalvular leak on your new prosthetic valve. Again, it's older data, but it is still data that is kept in mind, because when you consider the fact that the longitudinal studies take 10 or more years to figure out true outcomes. We're still working off of this data, although new information is being collected. And what they've found is that if you have even a small amount of residual mitral regurgitation after your mitral valve repair, there's a higher chance that you will have to come back to the OR for another operation. And knowing that a reduced sternotomy is a significant event with significant morbidity and mortality, surgeons are now aiming for a perfect repair to help prevent these kinds of issues. And the same thing's going on with aortic valve surgery and aortic valve repairs. They're aiming for perfect repairs, knowing that there's data that shows if it's not, you may end up back in the OR sooner than you would otherwise expect. Excuse me. So, what kind of things do we think about when we're looking at the mitral valve? And let me start by saying anytime you do a TE evaluation, of course you want to be doing a comprehensive exam because there's so many pieces of information there that may be key to your mitral valve diagnosis, even if you think they're potentially unrelated, number one. And number two, the incidence of finding other things during your mitral valve evaluation or aortic valve or whatever it is significant. You find things like ASDs or PFOs or regional wall motions from an acute ischemic event, or a myriad of other findings that lead us to know very strongly that you need to look at everything, not just the mitral valve, when you're moving forward. So the easy questions up front are, is there significant regurgitation or stenosis across the valve? One of the things that we key into in the OR is your baseline hemodynamics. And there's been a fair amount of literature published about the subject of baseline preoperative transthoracic or TEE exam done by the cardiologist versus the operative study. And it's pretty clear that if the baseline shows 3+ MR and your operative study shows significantly less, you need to at least consider the fact of what their hemodynamics were up front. Make sure you have equivalent hemodynamics before saying, oh, they're cured, they don't need this mitral valve done. So we look at their preoperative systolic blood pressure, their preoperative PA, CVP pressures, etc. And if you don't have a pre-op PA from your echo, we use our pre-op PA from our catheter that we put in prior to induction. We had this discussion last night. So you want to make sure that, one, not only do they have the same SVR, but also the same volume loading conditions. When you think about the fact that our pentothal and fentanyl is going to significantly drop their blood pressure, drop their preload, afterload, that's going to make mitral regurgitation go away, just like your enalapril or lisinopril is, that the cardiologists are using for their medical management of these conditions. And so we always make sure we give some phenylephrine, do a phenylephrine challenge and even a volume challenge to look and see what becomes of the MR as we do that. And it is not uncommon when you're looking at someone with coronary disease for a potential mitral valve repair to see your MR become moderate or severe as you give that phenylephrine challenge after induction. So the other thing that we look at in figuring out what to do moving forward is the mechanism of the MR and where on the valve the problem's located. And then the surgeons always ask the question, can it be repaired? That's a very tricky question. You need to know a lot of information about your surgeon, about what's going on with the mitral valve, and about other issues going on before you answer this question. Because some surgeons can do a complex commissural repair at A1P1, and some surgeons can't. So you're walking into a minefield when you tell a surgeon you've never met before, yes or no, it can be repaired. So unless it's very straightforward, I usually say, well, these are the issues you need to think about. So I talked a little bit already about the leaflets and in particular the segments involved. And as I said, the cardiologists used to just tell us it's anterior or posterior disease. Now they're getting more involved in A1 or P3 or whatever it is. Presence and location of prolapse or other abnormalities. Presence and location of flail segments. Location and severity of the MR jets. keep in mind that you may have more than one of any of these etiologies, and so when you do your complete evaluation, you want to make sure that you're looking for 1 or 2 or even 3 different primary problems on your mitral valve. The size of the annulus is important, and it's another minefield that you're walking into. The mitral valve annulus is not circular. It's not elliptical. It has a unique 3D shape that is the closest to a saddle for a horse. And so when you're measuring your annulus, you want to make sure that it's clear whether you're measuring the AP diameter, the medial lateral diameter, and then keeping in mind different elevations. And so that information is needed to help figure out what size ring to put in and even what kind of ring. The size of the left atrium is important for a couple different reasons. One, because based on whether it's dilated, in which direction, it'll be easier for the surgeon to do the repair or let their resident or fellow do the repair. The other is because if you have a markedly dilated atrium, you know you have an increased risk of post-op AFib if you don't already have AFib, and the surgeons may consider doing some kind of ablative procedure moving forward, or they may just tie off the left atrial appendage to, in theory, decrease the amount of Coumadin needed by that patient if they do develop AFib. And then the size and function of the left ventricle is very important here. You're going to change your surgical management as far as what procedure you do, what kind of cardioplegia you give, based on how good or bad the LV function is. The other thing to keep in mind in that is evaluation of tricuspid regurgitation. Long-standing mitral valve disease may portend right ventricular dysfunction and TR, so you need to know how much of that is present. So in doing your 2D and Doppler evaluation, I strongly recommend always starting with your 2D exam. We have a very strong tendency to hit the color button immediately to look for that color jet. But if you take the time to go through the entire image in 2D only, look at the actual structure and function of those leaflets, and try and figure out on your own where the failure of coaptation occurs, the color will add to your diagnosis instead of being your sole etiology, and you'll feel more comfortable with what you're saying is wrong. Color flow Doppler is a semi-quantitative scale. Keep in mind, when you have eccentric jets, based on laws of physics, the Coanda effect, the MR is always worse than it looks. So if it looks 2+ with a big eccentric jet, it's at least 3+. And then you're going to use CW and PW Doppler as well, especially in the face of stenosis, looking for amount of gradient across the valve. And then also after surgery, most of us will do CW Doppler evaluation of gradient after the repair or replacement, just to make sure we don't have functional stenosis. I put in here a table of all the various different measurements that we will look at to help determine severity of your mitral regurgitation. Keep in mind that mitral regurgitation, as I said, is an exceedingly preload and load-dependent state. And so there's, anytime you see lots and lots of different ways to do an assessment of severity, the thing to think of is, well, none of them's perfect, and that's true. So you're going to look at your atrial size, the area of your jet versus your atrium, the residual volume, the effective regurgitant orifice area, the jet area, and the pulmonary veins, all these things together to help figure out how bad the regurgitation is, keeping in mind that if it's mild, they may not intervene on the valve, and if it's moderate, they might. So you want to make sure you're pretty comfortable with what you're saying is going on. So mechanisms of mitral regurgitation, Carpentier came up with 4 different types. And you'll hear some people, especially the surgeons, use these varying discussions. We tend to talk more about functional versus anatomic. Annular dilatation is your type 1. And it tends to be more chronic. It can be related to ventricular dysfunction. Your type 2, notice you've got a papillary muscle rupture here or a chordal rupture. That tends to be more acute. It tends to be related to your myxomatous degeneration. And those are the patients that come in all of a sudden with SVT, AFib, shortness of breath, etc. Then your type 3s are divided into A and B, and they have some kind of functional issue within the mitral valve apparatus. All of these are potentially repairable. It just depends on who your surgeon is and what other issues are going on. I already mentioned baseline hemodynamics. Make sure you're back to where you started. Manage your SVR. Look at your baseline transthoracic echo if there is one. If it says moderate to severe MR and I'm not seeing that much, then I'm going to look and make sure, have they gotten a whole bunch of Lasix in the past 3 days, other things as an indicator as to why there's been a significant change. I already mentioned tricuspid regurgitation. Do they also need a tricuspid valve ring repair, etc.? And then the atrial size. So what is myxomatous valve disease? It's the most common primary indication for mitral valve surgery in the United States. It is actually an autosomal dominant condition, at least for certain portions of it. There's clearly abnormal collagen with increased proteoglycan weakness of the pars fibrosa, thickening and elongation of the leaflets. And as I said, there's several clinical subsets, and here's a pictures of 2 of the different options. Your Barlow's valve that you hear people talk about is typically seen in women in 3rd, 4th decade of life, and it's an echocardiographic finding usually. How many of you have had patients come in that say, I have mitral valve prolapse? Tons, right? And so the thing that we keep in mind when they come to us with the diagnosis of mitral valve prolapse is, most importantly, that they have antibiotic prophylaxis for prevention of endocarditis, because for that female subset with these valves, the biggest issue is endocarditis. They're at higher risk for it, and if they get it, then you're probably going to have to do surgical intervention, whereas normally most of these women can be medically managed and not need surgical intervention. The other patient population is the fibroelastic deficiency patients, and they tend to be an older patient population, and they tend to be the ones that come in with an acute chordal rupture or something needing a valve operation. So the mitral valve prolapse women are not at a significantly high risk of surgery. There is a risk there, but mitral valve prolapse in and of itself is not an indicator. They'll have to go to surgery eventually. So I borrowed these from a colleague, Dr. Shane Wise. He got these beautiful images, pathologic specimens, just to give you an idea of what myxomatous disease looks like. Here's normal valve. You see your leaflets here. They're thin, they're shiny. You've got your papillary muscles, and then you've got these nice thin chordal attachments. You can't tell here how pliable they are, but this is a normal valve versus this. See how this kind of looks like that first picture? There's a significant amount of redundant leaflet tissue. You can see even in this picture that your cords are lax, associated with prolapsing of the valve during systole. And so obviously that one was being worked on. So now let's get to the meat of the matter, doing your TEE exam. I talked about a comprehensive exam, and to do that you want to go through a systematic approach. Here's a schematic cartoon showing lining up your axis of your TEE probe, which is in the esophagus, with the heart, and then using your omniplane angulation to figure out exactly what's going on. Keep in mind now there is live 3D available, and I think initially we thought that we would jump straight to 3D and give up 2D, but I don't think that's going to happen. I've shown some 3D images to a lot of people who have no echo experience, and it doesn't seem that that's any more helpful to them in figuring out what's going on than the 2D is. It's going to be a great tool, but it's not going to, I don't think, be the be-all and end-all. Other companies are working on it, but we don't have it quite yet. Philips does. It's very expensive, just like any new technology. And as of right now, most of the 3D is mitral valve and not other areas of the heart. So one thing to keep in mind is that there are 2 different nomenclature systems, and the vast majority of the world uses the Carpentier nomenclature system for the mitral valve. You start with the interlateral commissure. You have P1, you notice some scallops here across your posterior leaflet, P2 and P3, ending in your posteromedial commissure. Notice that the anterior leaflet actually doesn't have any anatomic differentiation helping you understand A1, A2, or A3. So what we do is we just call it based on its association with those clear posterior scallops. Notice that the posterior leaflet has a very large attachment to the annulus. The anterior leaflet tends to be the larger leaflet when you're looking at it from here. And that annular posterior attachment is what leads us to be able to do posterior repairs better than anterior repairs because of the way they do the surgery. So there is a small contingent of the country that uses the Duran system of nomenclature. So if you go to a new hospital, just talk with your surgeons, which one do you use, and go from there. But keep in mind, in the Duran system, P2 is now P3. So if you say P2 and they're thinking this, you're going to have a little bit of a discrepancy until you both make sure you're talking the same language. We're going to talk about Carpentier today. So many of you may recognize this image. It comes from Dr. Reeves' textbook. And I think this is a really nice picture to keep in mind as you're doing TEE for mitral valve. And the reason it's nice is because this shows you your standard TEE kind of inverted ice cream cone. You notice that what you're seeing is the anterior leaflet over here for the most part, the posterior here, kind of like this looks. But this is what the surgeons are seeing. So you can't just point at your echo screen and say, this is this, because they can't make that leap either. So it takes a little while to be able to make the leap from taking this to understand where it fits in surgically. And so this is kind of a standard 4-chamber. Let's keep going. So I talked about the 180-degree view. Take that mitral valve, start at 0 degrees. You're going to cut through the anterior and posterior. Move to your 4-chamber, your commissural, your 2-chamber, your long axis, and note with each cut, we're going to change which portion you go through. And I'm going to go through these in depth. That was a 4-chamber. There is a commissural view. We know that because we see each papillary muscle, which means we know the commissures are here, and then the anterior leaflet in the middle with what we call the trapdoor view. And then your long axis view that we talked about yesterday with the aortic valve. Again, each gives you different imaging points to know which leaflets are involved. If you prefer, there's this study that is older but also gives you things to think about as far as your imaging. The most important thing to take away from this study is, especially in your mid views, your long, 2-chamber views, how you turn your probe is going to move you through very different segments of your leaflet. So you need to make sure that you're located in the correct plane anatomically. And then I included this Netter diagram as well to show how it correlates with the image that they used from this article. Also keep in mind the aortic valve is right here next to the anterior leaflet of the mitral valve, attached by what some people call the common annulus, the fibrous annulus, multiple different names for it. And these two are very close. So when you're doing a mitral valve and working on the anterior leaflet, you can get into the aortic valve and vice versa. So I'm not going to go through all these different images other than to ask you to keep in mind that your 2-chamber view may get you close to your trapdoor view, or it may get you very different images. So just make sure the rotation of your probe is also in line with what you think you're imaging. And that was a biplane study, which is why it's not as good as what we're looking at now. Okay, so let's actually go through some images. There we go. So this is a standard mid-esophageal 4-chamber view. You're seeing the left atrium, the right atrium, the left ventricle, the right ventricle, mitral and tricuspid valves. Notice the imaging plane is 28 degrees. Usually your 4-chamber is somewhere between about 20 and 30. The fact that you can't see the aortic valve anymore tells you you're on your 4th chamber. So I've highlighted the area in question here, and notice that we're going mostly through the anterior leaflet with a small amount of posterior, and for the most part, the posterior could be P1 or P2. The anterior is a fair amount of A1 and A2 as well. So you have a good idea that it's one of those two segments when you're looking at this view. And this is a normal mitral valve with anterior and posterior leaflets here. So then if you rotate your omniplane angle a little higher, this is usually around 60, but again, they're all variable. It depends on what you're finding. Notice that you're getting, you can see the papillary muscles on each side. You can frequently see your chordal attachments. And then you can see your posterior P1, A2, and P3 leaflets. And I've written on here, when this stops, okay. That's all right. This is just pointing here to this anterior side. By definition, the anterior side is this side of the image and inferior is this side. So if you keep in mind anterior side, you know that P1, A1 are more anterior, P3, A3 move over here. So you're moving from P1 to 3. And I'll show you an example of a P2 prolapse later, so you appreciate normal versus abnormal. And then this shows you the anatomy here. And again, as you rotate your hand through this, you'll go more anterior or posterior and change your imaging plane and give yourself more information. Rotate your omniplane angle a little higher. You see some subtle differences. Some of this, part of this image you can actually get just from rotating from that other image. But you have anterior mostly and a small amount of posterior leaflet, and you can see that here through the angle I've drawn. It's right at the P2, P3 line, so it's hard to determine which one you're looking at unless you rotate your hand, and then there's a significant amount of your anterior leaflet in that view as well. And then I've just attached to each image the cartoons associated with this from the comprehensive exam article that was published in 1999 by Shane Wise et al. And those of you interested in more information on echo, I'd strongly recommend looking at that because it gives you specific definition of all these different cartoon images that I've shown. So we're going to go a little bit higher on our omniplane angle. We're now going to be at our long axis. And notice that that's cutting square through P2 and A2. And remember I mentioned that the anterior leaflet's associated with the aortic valve, and here you go right here. You know this is anterior because here's the aortic valve, and you know that this is posterior, and not only is it posterior, it is highly likely that that's P2. So you see with those groups of images, whatever you see throughout every image gives you a very good idea of which leaflet is your problem. And then you can see all your surrounding structures as well. Transgastric basilar view is actually very hard to get, but if you can get it, you see that fish mouth kind of view that is very close to the surgical view, like in Dr. Reeves's picture, if you just rotate it. It gives you a very good look at your commissures and your leaflet structure themselves, and also regurgitation if there is any. Two-chamber view is a little bit easier to obtain. And what it shows you is some of your ventricular function. It clearly shows you your papillary muscles. You have a nice view of your subvalvular apparatus here. So if you have someone coming in with a ruptured pap muscle, usually this is flapping in the breeze. If you're looking at your subvalvular apparatus, you think it may be a rheumatic and it may not be repairable, you can look here. And then you can also get a good idea of ventricular function as well. So here's a 3D view of a normal valve. So what they've done in setting up 3D is decided to use color as an indicator of depth. So in this image, what you see in the front, the bright yellow, is the near field, and then back behind that is your far field. So what you're seeing is a normally functioning mitral valve, and imagine yourself sitting on top of the left atrium looking down through the mitral valve. So if you think of this compared to the last two images we saw, here's your anterior leaflet, here's your posterior leaflet. Notice how much annulus it takes up. Then your aortic valve would be up here anteriorly. And I'll show you some examples of abnormal pathology. I do a lot of hiking. That was my recent tip to the Tetons. If you've never been, it's beautiful. So I've talked a little bit about various pathologies you look at on different images: prolapse, flail, annular dilatation, ventricular dilatation, endocarditis, and then systolic anterior motion associated with a failed mitral valve repair or hypertrophic cardiomyopathy are things you need to keep in mind. So remember I mentioned this is your commissural view. There we go. This is a classic example of a mitral valve prolapse. So remember we talked about P1, A1, or A2 or P2, and P3. So what you're seeing right here is a portion of your P2 leaflet where the cord has broken off and it's just popping up above your annular line. So this is a simple, straightforward P2 prolapse. It is clearly the easiest to repair surgically. So if you see this, you can tell your surgeon, yes, you can repair it. Notice how that differs from the other image I showed you that was normal. Okay, so the thing to notice about this four-chamber view, you see these mitral valve leaflets? Here's your annulus here. They're not supposed to go above the annulus. And you see how each one looks really thickened compared to the other image we were looking at. And what this tells you is that you have bileaflet prolapse. So when you look at regurgitant jets, keep in mind that a regurgitant jet goes towards a restrictive lesion and away from a prolapsing lesion. But here it's both of them, so you're just going to have MR everywhere. There we go. So mitral regurgitation is seen as these aliasing colored jets here. The straightforward blue, the straightforward red are normal laminar flow, but the multi-mosaic color here is mitral regurgitation into the atrium during systole. So that's an indicator of severe regurgitation, and because of the extent of disease, this patient would have a mitral valve replacement. Here's another one. Pretty obvious, right? Now that you've gone through the basic anatomy, this is severe anterior prolapse. See how big that leaflet is? See how high it comes into the atrium during systole? And where would you expect your regurgitant jet to be? In prolapse, since it's away, you'd expect it to hug this back wall. And you can see here the regurgitant jet's hugging the back wall. So this is anterior prolapse. Some people would try to repair this, not everybody. Any guesses on whether this is anterior or posterior? Okay, so remember in your four-chamber view, your anterior leaflet's over here near where your aortic valve's located. So this is posterior leaflet. And on this view, remember, it's not necessarily P1. It can also be, it's not necessarily P2. It can be P1 or P2. You'd expect your regurgitant jet to go away. There we go. And there's your big regurgitant jet. So this is an example of a P1 prolapse. Now, I didn't show you every image on every one of these diagnoses just for purposes of time. But I am going to show you a second image here. I showed you a P2 prolapse earlier, which was right in the middle. And notice here when we turn our hand, the middle's okay, but you see something coming up over here, which is your P1 prolapse. And so by looking at both images, I was able to clearly delineate the difference. So I mentioned two different mechanisms. And here's one example. All right, that one doesn't want to play right now. But notice you've got two different jets here of mitral regurgitation, clearly different jets, telling you, same thing here, at slightly different view, that there are two different mitral regurgitations. And then here is that same patient after a complex mitral valve repair. What you now see are these little metallic shadows here, which are an indicator of mitral valve repair. Here's your anterior leaflet still intact, and then your aortic valves over here. And if you go look at your color, you can see that there's not all that bright aliasing in the atrium that was present before as an indicator that you fixed your mitral regurgitation. So I showed a normal 3D, and I hope that after this brief exposure, at least some of you can appreciate that this central segment here is very abnormal, and you can actually see in that image a ruptured cord. So that's a P2 flail. Can you all down at the other end see what I'm pointing to? If you look right here on your image, I guess I can circle it. Doesn't work with the video, huh? So for those of you down here, can you see that this segment here is not the same looking as the other one? So there's an example of more abnormal valve with 3D. Next slide. It seems to be frozen. It is a smart board. Still not advancing. Okay. So I just showed you an example of a mitral valve ring repair on 2D. This is the same thing on 3D. Notice in the center of the image, you have this structure here with all these intermittent little knot-looking things. Well, this is your actually ring that the surgeon has sewn in, and all these little dots are actually the sutures that you can see. And then you're seeing your anterior leaflet almost exclusively, because when they do these repairs, they typically sew in the ring so that very little of the posterior leaflet's involved in coaptation to prevent complications later. So one of the complications you have to think about is systolic anterior motion, especially if you have large amounts of redundant leaflet tissue here. Notice what happens in this image. If they sew their ring repair in incorrectly, that anterior leaflet, instead of staying up here and getting coaptation, moves right into your LV outflow tract. So there's now a blockage, and you get the same physiology of hypertrophic cardiomyopathy. I'll skip over this, but for those of you who are interested, there's a number of articles about mechanism of systolic anterior motion after repair, and they all go through measurements of a number of different areas within the mitral valve and the ventricle to help figure out what the risk is of mitral regurgitation and SAM after the repair. Some of the risks to keep in mind are excessive or redundant tissue, non-dilated ventricles, residual redundancy of your anterior leaflet, excessive resection, ring that's too small, not properly placed, or a hyperdynamic LV. So here's an example of a mitral valve repair that didn't go all that well. See if this one plays. I put the marker back down. That's all right. I can show them later. This one doesn't seem to be responding.
Doesn't seem to be responding.
Okay. Well, it just started to play. Did y'all see that? Let's try it once more. There we go. Look right here. I'll walk over here. Here's your ring repair. This is the anterior leaflet. And notice how, instead of going all the way up here, it's folding back on itself. So what we're going to look at now is what accelerated flow through the annulus looks like. Remember I mentioned that mosaic patterns are an indicator of turbulent flow. So you're seeing regurgitation here and all this aliasing in your outflow tract because the blood can't get out past that anterior leaflet. So you've got a couple choices. You can either give lots of IV fluid and phenylephrine, treat them like a hypertrophic cardiomyopathy. The other option is to go back and replace, move your ring or do a valve replacement. And they can look this bad and then get pharmacologic intervention and actually recover. So I try not to look at those initial images and determine whether or not they're going to come back or not. Got a few examples of some bileaflet mechanical valves just to show you. This is a standard St. Jude. This is a newer version of a mitral valve called an Onyx. They have slightly different echo signals. This one tends to require less Coumadin. It has better hemodynamics. And it's increasing in the U.S. markets. The one thing to know about that Onyx valve is that the hinge jet regurgitation is significant. So you need to make sure the surgeons have told you they put that valve in when you go look to see how much regurgitation is there. So we talked about a repair having systolic anterior motion. Now look at this one here. This is the same physiology, but this patient has a hypertrophic cardiomyopathy, and so they're getting that same anterior motion and LV outflow tract obstruction. So this one you would fix if you're going in surgically by just coring out a piece of that area. See, that's what they did here. They cored it out. Now you've got coaptation here, whereas you didn't before. And here's a still example of the amount of mosaic and regurgitation and stenosis, and then how it's gone away afterwards. One more pathology to think about in your evaluation, and we're seeing more and more of these patients because people are not going to the doctor and they're coming in with late-stage ischemic coronary disease, and that is the very problematic issue of functional mitral regurgitation or ischemic mitral regurgitation. What do you do about it? There's a big debate in the literature right now about taking moderate regurgitation and doing nothing, just medical management, intraoperatively milrinone, other agents, and then large amounts of ACE inhibitors afterwards. Other groups argue for ring repairs, and that's clearly outside the scope. We could do a full day series on what to do for these patients, but at the very least you need to keep in mind a few things about ischemic regurgitation. And that is exactly what's going on and do you think you can fix it medically. What I'm going to show you here is an example of a secondary cord that is being stretched by our dilated non-functional ventricle. Can you see that little hinge point right in the middle? And what's going on here is that this anterior leaflet can't move up and close because one of those secondary cords has been affected. And so this patient actually has severe mitral regurgitation through that area. And even though we can see the anterior restriction, we're seeing even more posterior restriction because your regurgitant jet goes towards restriction, and that's what this is showing you. I mentioned earlier the Coanda effect and eccentric jets. This is actually severe mitral regurgitation, even though it doesn't fill the entire atrium, because it's hugging the wall, and it takes a lot of energy to do that. I already showed you both of these. This is just an example of a bioprosthetic valve. There we go. You can kind of see these abnormal areas here, and that's a normal bioprosthetic valve. Here's an example of a valve with a hole in the leaflets from old healed endocarditis. See that huge jet right there? And it's not associated with anything else. The thing to keep in mind about this is that this one's actually not going to get better. You're going to need to do a replacement when you have a defect in the leaflet. It's not going to be dynamic. You're not going to be able to fix it by making the blood pressure go lower. Almost done. A few more things I wanted to show you just to keep in mind. There are almost as many mitral valve ring option repairs out there as there are heart surgeons in this country, and they will determine what ring they're going to put in based on the anatomy you find. I mentioned it's saddle shaped, so some people are now trying to make the rings fit the annulus exactly. This new ring here is called the Geoform, and notice how it's got that funky little hump in it. That's designed to elevate the posterior annulus in cases like the one I just showed you with significant posterior restriction. And the thing to know about that ring is it looks really funny on echo. So if you know they've put it in, you see this and you know exactly what's going on. It's not a ring that's been bent accidentally. It's purposeful. And it allows you to take those patients I showed you with those tight cords with the ventricular dysfunction and do a repair instead of a replacement. I've talked a lot about repair versus replacement, and there's a few reasons for that. One is the fact that there's pretty good evidence that when you do a repair and it works for a long time, which we're getting better at doing, they don't need the anticoagulation that the replacement patients do, and they have fewer long-term complications. The patients that get a repair tend to do better long-term. So the surgeons are doing more and more things to get the patients to the point that they can have a repair even in these complex situations. They can avoid Coumadin and all these other things. And then here's just a couple pictures of mitral valve replacement options. And for those of you that thought they would never be able to do percutaneous valves, we're now doing percutaneous aortic valves on a regular basis, and there's a group at Penn that is getting ready to start trials of a percutaneous mitral valve replacement. So we will be spending more and more time in the cath lab or the hybrid OR helping our cardiology colleagues get patients through these procedures without cardiopulmonary bypass in the future. So thank you very much. Anybody have any questions? Rebecca has a question.
In your septal hypertrophy exam, what measurements